what I say, man, a lesion, yeah, mass lesion. No, you can say cyst if you're sure that's what it is, but like again, I'm gonna say lesion is probably the best word. The lesion kind of covers everything. Lesion covers everything, you know. So I'm just really careful about what I. But if I'm talking to them, then I'll say how I'm feeling about it, right? I may say, oh yeah, you know, from looking at this, you know, hypervascular, you know, this person may have, you know, Graves' disease, you know. While I'm talking to the doctor, as far as my documentation, nah, I'm not gonna do that. I'm just gonna describe the pathology that I see. So, this is an example of look like a hypervascular thyroid right there. You know, probably associated with some kind of disease process. Maybe, maybe not. You know, maybe this person's thyroid is just, you know, it's vascular like that. But that was just showing you, don't forget to do a color evaluation of your thyroid. That's the whole point of that image right there. I'm giving you a color evaluation of it.
It is color. It can be color.
Color?
Color.
Turn the color Doppler on. So you have to include color Doppler. Again, you see how big this person has that box? Makes on the right image, the long image. Make sure you make your box a little shorter, or you know, so it's not taking up so much space, because you have a lot of empty space that you're not worried about on the posterior portion of that image. So let's talk about some pathophysiology. Who knew that pathology could be so pretty, right? Under the microscope.
I thought the same thing.
Okay, so the thyroid, guys, it is a host to a benign, malignant, autoimmune, and metastatic conditions. Okay, all of which have varied and often overlapping sonographic appearance. Remember, I said that the basis, I would say, of a lot of thyroid diseases would be Hashimoto's and Graves' diseases. Okay, they even have similar appearance themselves. So that's why I say just describe the anatomy to the doctor, because we actually need the laboratory test to find out what's going on with that patient. You just can't do an ultrasound and say this, because remember, ultrasound, we're just looking at masses. We need that thyroid uptake exam, that thyroid scan, in order to determine function. That blood test to determine function, right? So it's hard to say, oh, you have this and you have this, just based on an ultrasound. Okay, so as we talk about a lot of pathology, we're going to see that a lot of the pathologies, oh, that sounds like this and that's what makes it really difficult to understand sometimes, because that's what's called differential considerations, is that, you know, a lot of them can look like each other, you know, a lot of them can look like each other. Okay, pathology should always be documented in both longitudinal and transverse planes, just like we had over here with our complex lesion. Right? So I kind of didn't go in order of the book. I went in the order of the handout I gave you, okay? Because I kind of like the way that was organized. The book is kind of, when I was reading it, it kind of jumps a lot. It'll talk about this and it'll come back later. So I kind of like put all the information in one spot, and then I like to hit things twice. So I want to start with hypo and hyperthyroidism. Those are kind of like the basis to the majority of the thyroid abnormalities and disease processes. Okay, so hypothyroidism, and these are my pathology kind of sub-slides. So hypothyroidism, of course, we already know that's under secretion of the thyroid hormones, okay? Meaning that the body is not giving as much T3 and T4 as it needs, are also known as iodine insufficiency. Okay? It's the most common thyroid disorder. Okay? Hypothyroidism is the most common thyroid disorder. Okay? When it's really severe, you can go into a coma, what's called myxedema. Okay? Myxedema is a coma you can go into when you have severe hypothyroidism. Okay? It's actually can be fatal if it's severe and it goes untreated. Okay? Mixed edema is also the process in which what it does to your body, what it does to your tissue, because it kind of can have you have swollen, loose skin, you know, that has like fluid on it. Okay? So that's why it goes by that name. Okay? So know that alternate name for it as well. Okay? Hypothyroidism can be primary, or so you can have primary or secondary hypothyroidism, with the primary being the most frequent form.
What? I didn't understand what that meant. What?
Just like you can have type 1 and type 2 diabetes, but they both diabetes, right?
Oh, okay.
Okay. So you can have primary and secondary hypothyroidism, but primary hypothyroidism is the most frequent. I'm going to explain what those are on the next slide. Bear with me, bear with me, bear with me. Bang! There you go, right there. There you go, right there. So, primary hypothyroidism is intrinsic, meaning that the body is just not producing enough thyroid hormones itself. Okay, that can occur spontaneously, and is most commonly caused by Hashimoto's thyroiditis. Remember, associate hypo with Hashimoto's, hyper with Graves. Okay? Those are things I guarantee that's going to be on the registry. I guarantee that's going to be on the registry. Okay, so again, 75% of hypothyroidism cases are caused by Hashimoto's thyroiditis. Thyroiditis meaning inflammation of the thyroid, correct? Okay. And I'm going to hit this again. I'm going to hit Hashimoto's again. Right now, I'm still just talking about hypothyroidism. All right. So secondary is actually a central deal by something other than, you know, intrinsic factors, meaning that something else is causing you to have hypothyroidism, such as pituitary adenoma, some kind of new growth on the actual pituitary gland, inhibiting it from, you know, sending the thyroid stimulate hormone for the thyroid to secrete T3 and T4. Okay? Tumors impinging on the hypothalamus. Because remember, the hypothalamus, what does that control, guys?
TSH.
TSH, right? Okay. So if it's impinging on that, then the brain is not getting a signal to send to the thyroid that, hey, you need to secrete some hormones. Okay. So it's not going to get that signal. Therefore, you're going to be iodine deficient in your body. Okay. Radiation, congenital disorders, and medication are all secondary forms of hypothyroidism. Okay.
I just don't understand. These are reasons why you would have hypo.
Why you would have secondary hypothyroidism.
So if they give you pills it's because your thyroid is not they're not going to the root.
No, you know how medicine is, girl. Medicine is treatment. We need you to come back next month. We need you to come back next month and get these pills again. They ain't trying to cure you. I'm just messing with you. Find somebody that want to do that. Find somebody that want to do that. That's just my personal opinion, guys. Please, it's all in jokes and stuff. That's just what I believe is that, you know, that's medicine. It's medicine to keep you in the game, keep you in the loop. You know? It's business. It's business. That's why you're gonna be able to make the big bucks. That's why when you graduate, you're gonna come out making $38, $40 an hour, because we're gonna have these people had got their thyroid removed 15 years ago, still coming in there to look at their neck. Okay? Even though they probably looked at it 30 times since then. You know, that's the game. That's what I like to say. That's the game. All right.
Did you watch a documentary or something?
Huh?
Where you get this? Because my daughter, she watched a documentary and she keeps saying it's all the whole system. It's.
I mean, that's just my experience in working. Honestly, that's just my experience in working in this. You know, it's. Remember, we kind of talked about that a while ago, talking about what you call that medicine? I was saying where doctors overdo it so they won't get sued. Defensive medicine, something like that. You know, it's a money game. That's why when you go in there and your foot hurt or your knee hurt, they gonna order a femur, a knee, a tibia, and an ankle, right there. Yeah, they gonna, man, go and throw that CAT scan.
I don't know what it
get
is.
them approved for the MRI. You know, so
You got everything.
Keep going
let's
back
get
and forth.
everything. Let's get everything. So, this is the box. This is the image right you guys have on the slides right there. Just wanted to put it up there. I kind of broke this down into simpler forms because, guys, it's a lot of information in that book. It's a lot of information. I tried to give you guys the most important stuff that I thought, would be helping you, because I'm just trying to help you guys pass the registry. Okay? Some of this stuff is like, we're not in medical school, so, I don't need to know all of that, All right? So, some common signs and symptoms of hypothyroidism, guys, would be weakness and fatigue, dry skin, not able to handle cold, hoarseness, lethargy, weight gain, constipation, menstrual irregularities, hair loss, and decreased sweating. Decreased sweating are all examples of hypothyroidism. Okay. So when you think of hyper, just think of a lot of these signs and symptoms in the opposite form, right? In the opposite form. So hypo meaning under production, I'm not sweating enough, my skin dry, I'm tired all the time, I'm gaining weight because my metabolism is horrible, and you're weak. All right. So the sonographic appearance of hypothyroidism when it concerning, because remember, what is the percentage that's Hashimoto's? 75%. So most of the time we're going to be speaking from the Hashimoto's angle because that's what we're going to see most of the time. Okay, so we're talking about how Hashimoto's, it's going to change with time. It's going to vary, depending on what stage of the Hashimoto's you caught the person in. Okay, over time it becomes more coarse and more heterogeneous. It almost kind of looks like it's rocks. It almost kind of like rocks. It's very, very, very nodular. Okay, ill-defined hypoechoic areas separated by thick and fibrous strands. Again, when I have somebody come in there with Hashimoto's disease, guys, I'm probably not going to be trying to decipher where these masses are, because they're going to be too difficult to see where it begins and where it ends, because probably the whole thyroid is going to be inflamed. Okay? Remember, we're talking about Hashimoto's thyroiditis, right? So the whole thyroid is probably going to be inflamed. I'm probably not going to be able to see. How, what's that Marvel character? Is it our DC character? The orange guy in the movies? That looks like a rock? Is his name Rock? The Thing? Is that his name? That's not the Thing? It's one of these characters in the movies. He looks just like him. He looks like a rock. He looks like a rock. But that's kind of what the thyroid looks like when you see it, when somebody has Hashimoto's. Okay? It's going to be diffusely abnormal, and the normal parenchyma is not identifiable. Okay, because a lot of times these things are happening on the actual fibrous capsule of the thyroid and not the actual thyroid itself. Okay, remember the capsule is the outside part of it. So these are kind of inflaming the whole fibrous capsule as well. Okay. The best indication of diffuse enlargement is at the isthmus. If the isthmus is greater than 1 centimeter in the AP diameter, that's going to be associated with some kind of enlarged thyroid right there. So if your AP, I forgot what mine was. I don't think it was 1. I think it was like 0.5, but it looked big, right? So imagine what a 1 centimeter, thickened thyroid isthmus would look like. It looked pretty big. It almost looks like you don't have an isthmus. It looks like it's all just a straight line across. I have an image of it later. Okay. Early on, color Doppler demonstrates hypervascularity, like the picture I just showed you a few slides ago. Really, really, really vascular thyroid. Okay. So here's some. See right here, very, very vascular. You see those vessels going everywhere, and you see all this to show that it looks so different depending on what stage of the disease you catch it in. Okay, that's why I say you just can't decipher like, oh, that's this and that's that, because we're gonna look at a lot of pictures that look like this, right? We're gonna look at a lot of pictures that look like this colloid, adenoma right there. So, you have to know the actual clinical signs and symptoms, what it's supposed to look like sonographically, what are the other things that are associated with it, such as, you know, lethargy and, you know, weight gain and constipation and stuff like that.
And that happens because their body doesn't produce enough.
Absolutely.
Well,
And so it's just kind of, you know, exactly, not secreting, so it's kind of just staying in there. All right? Boom. So, real quick, any question on hypothyroidism? Hypo, under secretion, Hashimoto's, okay, mixed edema? Those are our key hitters right there. Those are our key hit points right there.